Hi, everybody, and welcome back to the Doctor's Lounge, made possible with Pro Cannabis Media and with myself as your host, Dr. Mary Clifton, and also, of course, because of you, because of the viewers who come and listen and pay attention and want to learn all of the latest that we know about cannabis from the doctors that we're hosting on the show. Today, I am so thrilled, really completely over the moon about sharing Dr. Jordan Tishler with you. According to the Americans for Safe Access, the top cannabis doctor in the United States. Thank you, Dr. Tishler, for agreeing to be on the show.
Oh, thanks for having me on. It's always a pleasure.
That's great. And you and Jimmy Young have had such a long, excellent relationship. So it's just wonderful that you could be here today and we could work together. We talked a little bit before the show about all of the different things that we could talk about during the very short half hour that we have together.
Quite a lot to address. So where do you want to start? Let's dive in.
Well, I think we were going to be thinking about sort of the legislation and all of the work that's being done around the country. It's really an exciting time to be in cannabis with so many different states legalizing cannabis medically and recreationally, and all of the interesting things around Delta 8. So tell us more about how you and your organization is working around the country on those various endeavors.
You know, when I started in this field, which is now almost 10 years ago, one of the things that really struck me was that there was a lot of discussion, political discussion around legalization, medical, recreational, whatever, but there was all of this sort of turmoil and hopefully progress. But the thing that was most interesting about it to me was that, particularly when we were talking about medical, nobody's asking the doctors. You know, there was like all the businesses and the advocacy groups and patient groups and all this stuff. And that's all great. I mean, I think everybody needs a seat at the table. But at some point I thought to myself, why isn't anybody asking doc, what sorts of products, what sorts of rules would foster better patient outcomes or even easier, patient interactions so that people can get what they need? And the answer was, well, because there was really nobody out there sort of saying, hey, here we are, like we kind of know what we're talking about. How about asking us a few questions, right? And it's still remarkable the ways in which we physicians are totally underrepresented in this discussion. And so a few years back now, I started the Association of Cannabis Specialists, which I need to remind myself is now actually slightly retitled to the Association of Cannabinoid Specialists. And one of the major goals was political advocacy. I mean, another major goal is education, right? Education for doctors like yourself and myself who do this kind of medicine, to make sure that we all are up to date on the literature, but then also to talk to our colleagues, those who are maybe not going to do this, right? Primary care doctors, neurologists, rheumatologists, the people who are going to see the people who need cannabis medicine, but aren't necessarily going to practice cannabis medicine themselves, so that they can understand what this is good for, what it's not good for, who to refer to, all of that sort of thing. So that's a major goal. But, to our topic, who's speaking for us as practitioners as we try to help people? And the answer was nobody. So we're now doing this. So we have a number of position papers that are freely available on our website. And we have a lobbyist in DC with whom we work. And we have a large and very active advocacy committee that is sort of reaching out the tendrils to try and connect with people. And, I think we're starting to see some acknowledgement. It was interesting. A few weeks ago, I had a conversation with a woman who is the chief health policy strategist for Senator Elizabeth Warren. And one of the things that was really interesting, first of all, very, very smart lady, clearly knows her stuff and very motivated. But she said to me, you're right, Dr. Tishler, nobody's talking about medicine in DC. all of the discussion at the moment is around legalization because of its economic impact, because of its social justice impact in terms of the incarceration of people of color, but nobody is thinking about patient care. And I say often, medical healthcare is a social justice issue. How are we ignoring this?
Really the lack of education at the individual patient level, but even more importantly, or at least as importantly, at the physician level, is becoming an ethical problem. I mean, we have a medicine that is not snake oil. It's effective in so many ways. We have some great research around all kinds of different disease states and topics with this. And you have an army of doctors that really have no understanding of how these products can be used.
Absolutely. I mean, it's part of, again, going back to the association, why the concept here is that endocannabinology is a field of its own. And God knows it's the endocannabinoid system is certainly pervasive throughout the organism. It's neurologic, immunologic, and obviously multiple other systems that are involved. So the way I kind of look at the cannabis world at the moment, excuse me, is like going back 100 years when endocrinology was new, you know, and people were saying, gee, we have these people with the sugar disease, and if we give them some mushed up pancreas, they seem to not die on us. So, you know, we're at sort of, I think that maybe a little further along than that. But, you know, what are we giving people? We're sort of giving people mushed up plant material at the moment. I do think that as, you know, the research comes in, we're going to be able to not only use that plant material better, but I do think that we're going to also learn a lot about the pharmacology, both of the plant chemicals as well as the human beings. And I think ultimately we'll come out with even better products that are more specific and more targeted. But it's easy to get like frustrated because we're not there yet. And to say, oh, there's just not enough data. Well, you know what? There weren't enough data in 1920 either, but that didn't stop the march of endocrinology into being its own field with real science and real effect on people's lives. So
yeah, it was just 100 years ago that Banting and Best did all of their research. It was initially on dogs, and then they switched over to humans. And boy, that first young man who was treated with diabetes ended up having a really long life. Died in his late 50s, and did a whole bunch of work in wood art. It's a fascinating story. I love the story of Banting and Best really thinking about insulin and coming forward with it. And I agree with you that this lack of education and this lack of understanding of this as a medicinal plant primarily is probably contributing to some of the problems that we're having with not having the right strains to treat people, because as it becomes an increasing focus on the profitability and everybody focuses on the recreational products, then it's all about the THC to CBD ratio, and nobody's thinking about the myrcene or increasing the pinene so that it makes it a little bit more effective without so much of the memory difficulties. You know, a lot of these very subtle changes that you see population to population based on plants that have sort of grown with the population over hundreds of years, we just lose that with all these hybridizations.
No question about it. And I think that, you know, we have certainly homogenized the plant at this point. Whether we can go back, you know, 100 years or more, and whether we have data that are scientific enough or accurate enough for us to sort of be able to say, look what we've lost. But I think, you know, ultimately we're gonna find that the strains that we have now are often just kind of very vanilla and they do what we need them to do, but can we do better? And I think the answer is probably yes, but it may end up turning to be rather more pharmaceutical than botanical. I guess we'll have to see.
Well, I mean, you even can look at New York State and their rules where they offer a hard pressed tablet or an oil or a vape, but you're not able to buy flower in New York. The whole concept of an individual particular flower being more effective in one setting versus another is it just doesn't even exist, and it starts to make you think that it is just a THC to CBD ratio, that's the only thing that's contributing to the management of the underlying condition. But I don't think that's true at all.
Yeah, I think that we all have a sense that there are other moving pieces in this puzzle that are not as simple as THC and CBD. And certainly, for example, the anti-neoplastic effects that Dedi Mary is showing clearly are obviously strain, not just strain, but also then tumor specific. So clearly there's more going on. I mean, we know that if you put THC in cell culture with tumor cells, that you'll kill some of them. But it's also clear that if you vary the strains and they all have CBD and THC in them, and some extracts work better than others, then clearly there's some other components that are important. I think it'll be fascinating when Dedi figures out what those are. By the same token, we can say that whatever those differences are, they need to be amplified, because we're not seeing enough of those differences make a difference in clinical practice for patients that we can say, oh, you definitively need more, well, to use your example, myrcene or pinene or whatever.
Yeah.
Again, I think, it's so early that we want to get to the punchline, and we have to do the work. We have to do the science. And of course, back to the politics, the government is not helping us get to that finish line in any fashion.
Not quickly, no. I wondered what you were thinking about and what part of the research was driving your thought process. So it's interesting that you bring up the anti-cancer products, and it sounds like you're very interested in these products, be concentrating minor cannabinoids, for example, for pharmaceutical purposes.
I think that that's likely to be sort of the longer term path. And I think that, the botanical material that we have now is extraordinarily helpful. And I'm grateful that we have access to it now so that we can help patients. But I don't think it's necessarily sort of the end of the story. Many, if not most, of our pharmaceuticals started out as a plant product, and we've simply refined them, whether we're talking about, aspirin or the other one that comes to mind is Taxol, right, which just comes from the yew tree, and in fact is a terpenoid. We've gotten this kind of weird place in the last maybe 30 or 40 years where we have forgotten that the plants are the primary donors of our medicines, because we think, oh, well, we can synthesize them. And we may ultimately synthesize them for mass production, but we need to look at our natural environment for the sources of the ideas and the understanding. I got no problem with using plant material now. I just think that ultimately we can optimize beyond that.
I mean, that's really interesting that you take it back to plants being the source of the medicine, because that's absolutely true. You do forget that Valium comes from a plant. So many of the medicines that we're utilizing all the time, aspirin is being derived from a plant. So there are a lot of powerful herbs. I mean, even just in simple things, like I was reading about hair loss and using rosemary oil this weekend, that we don't think of these herbal products as being really powerful, but cannabis is just an excellent example of how powerful these herbal therapies can be.
Clearly, I need a little rosemary.
Well, I'll be curious to see how that works. I was reading about it, and I can't tell if it's an oil-based or a water-based, what part. You never know when you're using the essential oil, if you're throwing out the valuable product when you throw out what's, in the watery component of it. So I think if you're going to do it, I would dilute it in water and oil and give it a shake before you spray it on.
Make a poultice or something,
increase blood flow. There's other ways to grow hair too. I don't know if nioxin comes from a plant, but is there any particular strain right now that's catching your eye as being especially interesting for its medicinal benefits?
You know, I don't know if I can answer that question. I really, frankly, try to ignore strains as much as possible, at least on the clinical side.
Why is that?
I really just find that they are unreliable, and they don't seem to influence clinical outcomes so much as they seem to influence preference or something like that. And, so I think a lot of my patients initially come to me and they think Dr. Tishler is going to tell me to go buy, Blue Dream or, something Kush or whatever.
Mm-hmm.
And I never do. And I usually tell them, look, I don't think it's going to make any difference to whether this works for you, number one. And number two is, even if I told you to go get Blue Dream, when you go back to the dispensary, it's not going to be there, right? And so you need parameters by which you can choose from what's available. And so that's what I tend to give people. I tend to tell them, I think you need this kind of THC level, blah, 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 which gets back to your point about it's being somewhat crude at this point. But that's what we have access to. And it's unfortunately also only what data we have that support it. I think you and I both know that there are refinements to come, but I don't know that we have enough data at the moment to know what they are. And I certainly don't want to tell my patients that they should be looking for something that's more specific than we really can support or that they can find, right? And if I say, look, I want you to go to find a strain that's 15% THC and 3% myrcene and whatever, I think that they're going to have a hard time finding that. And so I've been, there's a certain practicality in that. At some point, I'm very hopeful that our data progress to the point where we can say, all right, in this disease state, we need this much THC and this much myrcene and this much pinene. And then what I really want to do is get to the point where I can then write this into a computer, right, as a prescription that then goes to the dispensary of their choice, and then they have that, right? And so they sell that to my patient, and they sell only that to my patient. So we haven't really touched on this, but if you ask me what is one of the largest problems that we face in patient care, it's that the dispensaries change everything on our patients. It's not just that they can't find or won't find again the product that was working. That's a huge problem. But the biggest problem is I will tell my patient, okay, I want you to get this kind of cannabis. I want you to use it by vaporization, or I want you to go get an edible. It's a little gummy with 5 milligrams of THC in it. And then they get to the store, and the guys behind the counter of the store, they start saying, well, here's a direct quote, actually. A patient told me this. He went to a particular dispensary I won't mention, and the guy behind the counter says, oh, I don't understand what your doctor's talking about. Forget what he said. I'll tell you what to do.
Whoa. Yeah, that's not what you want to hear. But I do sometimes wonder if it's going to end up coming down to that. I mean, I think you have these individual humanity, these people in front of you that we can't, even with all of our best medical knowledge and our best guesses based on seeing, thousands of patients before them, we can give them a recommendation, and then it may cause them to feel anxiety or panic, or make them feel paranoid, and in a way that we just didn't anticipate. And even though, these test tube studies suggest that something is going to flow in a certain direction based on the availability of the THC or CBD ratio, or based on the different terpenes, is it actually going to play out that way? Or maybe it is that certain products are just the great standbys, like gelato and wedding cake and harlequin and cherry pie, just, products, sunset sherbet, just products that really so many people consistently get a great experience with. I mean, it sort of reminds me that of the best greens, like what's the most potent green in your diet? Well, the most potent green is the one you're actually going to stick in your mouth. You know? So we can tell you
That
to
takes
eat
kale
kale
right
all
off
day
the
long.
list for me.
Right. So we can't, we just can't recommend kale routinely and say that's the answer for everybody, because some people are just not going to eat it. And then we haven't accomplished anything. Whereas a product like gelato is so universally loved. I wonder if it'll end up coming down to those universal loves. I wonder if we'll ever get the research to the point where we'll be able to dial in all the terpenes as much as we think we can. Because even when you're looking at the individual, cell lines, you're only looking at one person's lung cancer or one person's breast cancer that line is. So you're not really looking at thousands of people and their responses to that particular medicine. I mean, that type of medical research is so far off from being available to us.
Yeah, I think, going back to the cell line issue, it's the starting point. And I think that, one of the major issues in this field is the desire of everyone to be able to generalize from cell culture or animal models to human beings. And it just doesn't work that way realistically. Once we figure out what's going on in a cell line, then we can start talking about doing the work of figuring out what happens in a human being.
Yeah, because you'll hear these
so
generalizations about THC and breast cancer, for example. I'm sure you've heard this, where patients have said they shouldn't have too much THC because it can stimulate breast cancer. But that's one study on one cell line and doesn't really equate to, the overarching amount of data we have about different cannabinoids and different cancers.
Yeah, exactly.
For example.
I absolutely agree with you. It's even a well done study, and there are so few that are well done, even those that are, you need to look at the context. It has to be replicated. It has to be understood in the context of what the study was really, like if you're doing this in a test tube, it's in a test tube, right? And you just can't say, well, look, it killed cancer, so now we should all be doing, dabs of RSO, right? I mean, there is a progression of the science that actually makes a whole lot of sense. But unfortunately, for most people who are looking at these things, who also have a little confirmation bias, because generally they want cannabis to be good for these various things, they don't necessarily understand the sort of minutia and painstaking process and very slow and expensive process that gets you from that test tube into a medicine that is available to human beings. But we'll get there. I think we will get there. I think to your point is, I think we will be able to dial that stuff in. Whether we can necessarily dial it in exactly for each individual, or whether we're dialing it in, more on the basis of what's wrong with them, so you have a certain kind of cancer and you have certain markers and stuff, like we do now with more conventional chemotherapy. I think we'll get to that level of specificity.
And what do you think about, the consideration for various comorbid conditions? Like somebody comes to you for management of their cancer, but they also have some full tilt anxiety that they don't have good control of, or they're dealing with some, chronic tendonitis that would also benefit from treatment. I mean, do you feel like some of these overlapping scenarios really make a big impact or less of an impact when you're looking at the overall situation for a patient?
That's a really interesting question. I always try to find the simplest regimen. Why? Because no regimen that is not adhered to ever helped, right? So, you want to give your medicine in as few forms as possible, as few times during the day as is possible, in order to sort of make sure that you're getting it in.
Yeah.
And
so your focus is a lot on the ease of administration and the ease of being compliant. Again, because if you look at a medicine you take once a day, you can get 80% of your patients to do it. But if you go up to twice a day, your compliance rate drops to like 30 or 40%. It's shocking how hard it is to take a medicine twice a day.
I take a bunch of medicines myself once a day, and I am very good about it. There was a period of time a few years ago, however, when I got put on a twice a day medicine, and it was, and this was for something actually that was rather life-threatening. And,
oh gosh.
And I still had, I was on Xarelto. you don't want to mess around with that.
Yeah.
And it was really challenging to take it twice a day.
You
Now
know,
imagine that you're taking something 3 or 4 times a day, and sometimes it's inhalation, and sometimes it's a gummy, and blah blah blah. It gets confusing, and then when you see your patient again and you say, well, how did it work? And they say, well, it didn't work that well. And all right, well, what are you doing? And you just figure out that you gave them something that was so complex that they weren't doing it in a way that was likely to work. Then,
right.
frankly, I see that as my own fault, right? I mean, I need to make this so that it is simple, right? So
Yeah.
to your point, like if somebody came in and they had sort of multiple issues like that, I want to find the regimen that's going to cover the most bases, right?
Because I never understood how Xarelto got the market share that it did for oral anticoagulants with its twice a day dosing. I thought that's never gonna fly compared to all the other products we have available. And yet it did get a substantial market share. And I think in some ways cannabis has an edge with, over Xarelto or another twice daily medication or 3 times a day medication, because it has such a fantastic side effect profile. That if you do have a patient who is dealing with their primary issue that they came to you for, let's just say, for example, cancer, but they also have some anxiety that's making it difficult to sleep, then the twice a day dosing structure is going to allow you to treat all of their conditions.
Absolutely.
Yeah. Can you comment for just a second on the insurance or the lack of insurance coverage or the issues that insurance has impacted your ability to see patients or patients to get the medication that they need?
Yeah, it's an interesting thing. So the first thing is a lot of my patients tell me cannabis is very expensive. I don't doubt them. I mean, that is to say, I think compared to many conventional medications, it's not very expensive at all. But the thing is that we don't see the bill for most of our conventional medications. And so it's kind of an apples to oranges comparison. Depending upon how you feel about healthcare insurance, might lead one to different conclusions. I'm not a big fan of healthcare insurance, but quite frankly, I haven't come up with a better solution. I do think that we need to get to a point where cannabis is covered by the insurance. There have certainly been a number of studies that have shown that sort of in terms of treatment regimens, people are not only safer and oftentimes better treated with cannabis, but the actual bill to the insurer, if they were going to pick it up, is somewhere around 50% of what it would be if we were using, for example, opioids for that treatment.
Pain management.
So, it's not a matter of rocket science whether the insurance companies would want to cover that bill rather than the larger bill. It's just a matter of the politics right now. These insurance companies aren't really in a position where they can do this. So I think that that's something that, again, has to come from Washington before it's really viable. One thing I would add, though, that isn't widely understood is that when patients come to see me, we send them what's called the super bill, right, which is the documentation that goes to the insurer for the doctor visit. And quite frankly, they get reimbursed.
Oh, that's
nothing
wonderful.
on it that says cannabis or pot doc or any of those sorts of things. It says, you came in for back pain and, and this is what it cost. And, there's some codes on there and that's all it says. And then, so I found that, of the patients who go through the process of submitting that to their insurer, almost all of them have gotten some reimbursement, maybe not 100%. And I think that what startles me is I think very few of my patients actually submit it, which I think is interesting.
So does that allow you to get your medical cannabis card potentially during that office visit and get that visit covered by your insurance?
That's exactly my point.
That's
Yeah.
great. That's really good to know. Yeah. And patients should be aware that they can definitely submit that to their insurance company, although that is such a terrible headache. So I can understand why they don't too.
The way I look at it is, look, you download the form from their website, you send it in along with the form that I give you, and you cross your fingers. And, if they say no,
You're not
really
out
any
anything
worse
but your
off than you were
time.
before you sent it in.
Yeah.
Right? So
Yeah.
assuming you can spare an envelope and a stamp, I think it's worth doing, and if you get money back, great. And if you don't get money back, well, it was worth a try.
Jordan, it's been such a great conversation with you tonight. How can our listeners get a hold of you? How is there any mechanism where people can reach out to you and hear what you're thinking about? I know you're super active on Twitter. I always enjoy following your tweets.
Thank you. So if people want to get in touch with me and my medical practice, the best thing to do is to head to our website, which is inhalemd.com. So the word inhale followed by md.com. And on that website, not only can you reach out to me, which would be wonderful, but we've got hundreds of articles that we've written over the years about various medical conditions and various cannabis related things and how these things go together. So it's a really good, unbiased place to sort of get some basic information.
Yeah, and I would vouch for that too. Just really high quality blogs. Plus, you have some telemedicine options available to make it easier for patients during these times and just to make it easier for patients in general. And located in Massachusetts, right?
Yes, we are located in Massachusetts. We're doing telemedicine 100% now, and I'm taking care of patients all over the world. I mean, I saw somebody just this morning in Georgia, and again this morning in Ohio. So, people should feel free world over to get in touch. And if they're interested in this as sort of an either professional or political thing, then they should really reach out to the Association of Cannabinoid Specialists, which is, the URL is a little funky. It's cannabis-specialist.org. So that's a great place. And there's a lot of information there on the various political endeavors, as well as a range of educational products where people can, watch a simple video, or if they're interested, they can do things like take a 20-hour course on medical cannabis treatment that's really aimed at physicians and other healthcare providers. But if anybody wants to take it, it's there.
Really there on the leading edge of all of the education and the legislation that's necessary to move this forward. Dr. Tishler, thank you so much for coming on the Doctor's Lounge. And thanks again to Pro Cannabis Media for sponsoring us. And also, of course, to all the viewers who are listening in. Thank you. Thank you all for coming. There wouldn't be a show without you. We'll see you next week.